Welcome back to the deep dive. Today we are strapping in for a fast-track, high-yield journey into a domain of medicine that is, incredibly common, yet carries just an immense amount of emotional weight and clinical complexity. Benign breast diseases, or BBD.
It really does.
Mm-hmm.
This is an area where the clinical noise can be, well, it can be overwhelming. Sources on BBD span everything from simple, almost irrelevant anatomical findings all the way up to conditions that fundamentally redefine a patient's risk of future malignancy.
Right. And for you, the learner, the goal today isn't just to list every single potential diagnosis. Our mission is to give you the clinical blueprint, the architecture that expert surgeons and clinicians use to structure this vast topic. We're going to unpack how they so quickly sort thousands of potential presentations into these really clear categories: watchful waiting versus action needed.
And that's the whole game. Because in this field, classification isn't just some academic theory. It is the ultimate shortcut to dictated management.
Exactly.
We're aiming for clarity and context here by, distilling the clinical philosophy. By the end of this deep dive, you should really understand the organizing principles of these non-malignant conditions: developmental, inflammatory, and proliferative. And crucially, understand the specific features that clinicians deem highest yield when assessing future risk and the urgency of intervention.
Okay, so let's dissect that decision matrix. We need to figure out what sets the low-stakes conditions apart from those that fundamentally change a woman's life trajectory. Let's start with the foundation, the crucial spectrum of risk.
The clinical community absolutely needs a standard operating procedure for breast complaints, and that really begins with classification.
So why does this matter so much, beyond just, putting labels on things?
Because the classification immediately dictates the intensity of the risk assessment, and critically, the required follow-up strategy. I mean, think about it. Miss a high-risk lesion, and you fail the patient.
Right.
But on the other hand, if you overtreat a low-risk variant, you're incurring all this unnecessary anxiety and surgery.
So the classification is basically the core map. It shows us which path of surveillance or intervention we need to take.
Exactly.
Okay, so let's start with the broadest umbrellas the source material gives us. Those 4 major categories that really encompass all of BBD.
Right. These 4 categories give you a really comprehensive scope.
Let's start with category 1. This seems like the lowest risk, at least in terms of pathology. It's often related simply to anatomy, right?
Category 1 is developmental conditions, and that's exactly what they are, essentially anatomical variants. They represent variations of normal, not really acquired disease processes.
So what are some examples?
The sources specifically highlight conditions like polymastia, which is the presence of extra breast tissue, maybe in the axilla or along that embryonic milk line, and also polythelia, which is just having extra nipples.
Okay.
There's also juvenile hypertrophy, a condition involving excessive, often on one side, growth of the breast during puberty.
So these are really only important because you have to recognize them as normal variations, not something sinister.
Precisely. Their management is typically reserved for cosmetic concerns, or if they become symptomatic, but they carry almost zero pathological risk on their own.
They're like structural footnotes, not diseases needing complex pathological surveillance.
Yeah.
Okay, so moving to category 2, which sounds a bit more acute, something that often overlaps with, say, general infectious disease principles.
Yes, category 2 is inflammatory infective. This covers conditions that are acutely symptomatic and require resolutions in active process. Here we find things like acute mastitis, often related to lactation and infection,
Right.
localized abscesses that require drainage, granulomatous mastitis, which is a trickier chronic inflammatory state that can sometimes mimic the appearance of carcinoma on imaging,
Oh, interesting.
and ductictasia. The primary concern here is the acute infection, managing the pain and making sure the inflammation resolves to prevent complications like sepsis.
Okay, now we get to what feels like the conceptual core of our deep dive. Category 3. This is where the entire risk assessment seems to hinge, and where the literature really forces clinicians to dedicate their focus.
Absolutely. Category 3 is proliferative, without atypia. This is where the core understanding lies and where that critical distinction is made.
And there's a key phrase for this, isn't there?
There is. The high-yield clinical mantra, the exam line emphasized in the source material, is defining. Benign breast disease is best understood under the umbrella of proliferative versus non-proliferative changes and degree of atypia.
That is the pivotal concept. Okay, let's break down proliferative without atypia first. What does proliferation even mean here? And if the cells are growing, why is this still considered low risk?
So proliferation just means cellular growth or multiplication. When we say without atypia, it means the new cells, while they're increasing in number, maintain their normal, organized architectural appearance. They still look healthy under the microscope.
And this often gets lumped under one big term, right?
It does. This spectrum often falls under the banner of fibrocystic change, FCC. This group includes conditions like fibroadenoma, which is an overgrowth of glandular and stromal tissue, and sclerosing adenosis, which is a complex proliferation of ducts and acini within a fibrostroma.
So even though there are cellular changes happening, the actual risk elevation is pretty minimal.
It is, maybe only 1.5 to 2 times the baseline population risk. So management is largely focused on symptom control or removing the mass if it gets too large.
Okay, so low relative risk, even if there's a mass. But then we cross the line into the proliferative with atypia group. This sounds like the tightrope walk of benign disease.
It really is.
Can you walk us through what sets conditions like atypical ductal hyperplasia, ADH, and atypical lobular hyperplasia, ALH, apart at the cellular level? Why do they warrant such a dramatic increase in concern?
This is the most crucial segment. The term atypia means lacking conformity. So a pathologist looking at these cells sees architectural disorganization and morphological changes. The cell nuclei might be larger, darker, or more pleomorphic, meaning varied in shape.
So they just don't look right.
Exactly. The changes aren't enough to classify the lesion as cancer, like a carcinoma in situ, but they are clear precursor lesions. They indicate that the cell line is already heading down a pathway of malignant transformation.
And I imagine the specific location, ductal versus lobular, matters a lot.
Enormously. So atypical ductal hyperplasia, ADH, involves proliferation and atypia that's confined to the breast ducts. ADH is often considered a direct precursor to ductal carcinoma in situ, or DCIS.
Okay, ALH.
Atypical lobular hyperplasia, ALH, involves similar atypical cell changes, but they are happening within the breast lobules, the milk-producing glands. Now, while ALH also carries a high risk, its clinical significance is sometimes a bit different
Oh, so?
because it signals a widespread risk across both breasts. We call it the field effect. Finding ALH in one breast suggests the entire breast tissue across the body is vulnerable.
Wow. That is a massive distinction. So finding ADH means we need to excise that specific ductal lesion very thoroughly. But finding ALH means we're looking at a much broader bilateral surveillance strategy because the whole field is affected.
Precisely. And the implication is immediate and significant. Patients with confirmed ADH or ALH have a cancer risk elevated by 4 to 5 times the baseline population risk, sometimes even higher.
And that changes everything in terms of management.
It mandates not just intense surveillance, so frequent mammography and clinical exams, but often prophylactic measures. Things like chemo prevention with drugs like tamoxifen, or sometimes even surgical excision of the area where the atypia was found, just to ensure the margins are completely clear.
It's just startling how a microscopic distinction, the presence of atypia, is the difference between a patient who just needs reassurance and one who is now on a long-term, high-intensity cancer prevention protocol.
And that connects right back to the core concept. The classification immediately stratifies the patient's future risk profile. If you connect this to the bigger picture, proliferative lesions with atypia are the key area where the radiologist, the surgeon, and the pathologist have to work most closely together. The decision to intervene preemptively rests entirely on that finding.
Okay, finally, let's cover Category 4 tumors of stromal origin and these other miscellaneous conditions. What falls in here?
This category includes lesions that originate from the supporting tissue, the stroma rather than the glandular tissue, or some unique traumatic or vascular pathologies.
And what's the most critical one in this group?
The most critical inclusion here is the tumor. This tumor is characterized by its high rate of stromal overgrowth, and it has what we call borderline behavior.
Borderline behavior. What does that mean in practical terms?
It means that while many phyllodes tumors are benign, they can be borderline or even frankly malignant, and their clinical hallmark is very rapid growth. This category also includes things like fat necrosis, which can look exactly like cancer, but is usually the result of trauma and conditions like Mondor disease, which is a thrombophlebitis of the superficial breast veins.
That initial structural framework is absolutely indispensable. We've defined the entire spectrum, from simple anatomical variations all the way up to these high-risk precursor lesions. So now, how do clinicians apply this knowledge when a patient first walks into the clinic with a new complaint? Before touching the patient or ordering a single scan, the source material introduces a really elegant mnemonic, the triple ABC framework, that guides the initial clinical assessment. For a doctor facing a potentially daunting new lump, what's the immediate structured workflow they follow?
Yeah, the initial consultation is structured kind of like a funnel. It's designed to rapidly filter the patient's presentation into high-probability differential diagnoses and to assess the clinical urgency. The triple ABC framework captures the three most crucial variables that dictate this initial triage. It's a very efficient diagnostic checklist.
Okay, let's start with A. This seems like the most immediate and objective clue.
A is for age. Age provides the necessary context for probability. Certain conditions are so overwhelmingly common in specific age brackets that finding a presentation outside that window should instantly elevate suspicion.
Can you give an example?
Sure. Think of the 15 to 25-year-old range. Over 90% of lumps in that group will be a fibroadenoma. So if a 17-year-old presents with a lump, the differential starts strongly leaning benign. Conversely, fibrocystic change, FCC, is the classic condition of the premenopausal years, say 30 to 50.
And if a patient falls outside those windows, let's say a 55-year-old woman, postmenopause, who presents with a brand new lump.
Then the clinical alarm changes entirely. Postmenopausal looks are cancer until proven otherwise. Without the mitigating influence of hormonal fluctuations, new masses in older patients carry a significantly higher probability of malignancy. Age just sets the risk matrix before you even feel the lump.
Excellent. Okay, so B then focuses on the specifics of the physical exam, breast lump characteristics.
This is where the physical description paints the picture, sometimes literally. Clinicians are focusing intensely on the feel of the lesion. Is it mobile or is it fixed? Is the texture hard or soft? What are the margins like? Are they smooth or irregular?
And what do those characteristics suggest?
Well, a smooth, rubbery, mobile lump, like the classic fibroadenoma, tends to reassure the clinician. It slides around in the tissue. This mobility suggests it hasn't invaded the surrounding structures.
And the opposite.
In contrast, a hard, fixed, irregular mass that's tethered to the chest wall or pulling on the skin. That is the classic red flag. The lack of mobility indicates potential infiltration and demands immediate, intensive investigation.
So if the lump feels like a marble rolling around under the skin, that's reassuring. If it feels like a rock cemented in place, that's concerning.
That's the precise visual distinction. Finally, C, which is the historical context of the symptoms. C stands for cycle relation, pain, and discharge. This connects the lump to the patient's endocrine and ductal systems. If the patient reports that pain or nodularity increases dramatically in the luteal phase, that week or two before the menstrual period, it's a powerful indicator of hormonal influence.
Which points to?
Almost certainly points toward fibrocystic change, FCC. This cyclical pain is caused by the surge in hormones, estrogen, and progesterone, leading to fluid retention and stromal swelling.
And discharge is another huge differentiator in C.
Oh, absolutely. We look at three key factors for discharge. Is it spontaneous, meaning it happens without squeezing? Is it unilateral, so from one breath? And what's the color?
And bloody discharge is a major one.
Spontaneous, unilateral, bloody discharge is alarming and points strongly to an intraductal papilloma or even a malignancy. Conversely, a sticky, greenish, or multiductal discharge often suggests a more chronic inflammatory or hormonal process like duct ectasia.
So A sets the stage, B defines the lump, and C provides the functional context. It's concise and very effective. But the source reminds us that the clinical approach requires more than just the ABCs. It requires the full risk profile.
That's right. Beyond the immediate presentation, doctors must gather these essential contextual factors that inform the patient's overall risk matrix. They have to determine the patient's family history of breast cancer, particularly in first-degree relatives, and at what age it occurred.
Right.
And if the patient has a known or suspected BRCA status or other high-risk genetic mutations, surveillance must be heightened significantly. And finally, any previous breast interventions, biopsies, excisions, radiation history, all of that must be reviewed, as it might influence current findings or management decisions, like scar tissue mimicking a new mass.
This holistic approach ensures that treating a lump is always customized to the patient. Recognizing that a fibroadenoma in a young woman with no family history is fundamentally different from a fibroadenoma in a woman with a strong family history and a positive BRCA status.
The goal is never to manage just the pathology, it's to manage the patient's entire risk journey.
Now we get into the specifics, using that ABC framework to guide our understanding of the most common and clinically significant BBDs. For each of these conditions, we really need to know the specific fingerprint, that unique combination of age, characteristics, and management that makes it stand out.
Exactly. We need to understand the unique characteristics that allow for rapid, confident recognition and therefore proper management. We've got 8 key conditions to discuss.
Okay, let's start with the classic of youth, fibroadenoma.
Fibroadenoma.
Mm-hmm.
As we noted, the key feature here is the age group. Overwhelmingly young women, 15-25 years. It's a solid, benign tumor of the fibrous and glandular tissue.
And its physical characteristic is the defining feature, right?
It is. It's well-defined, rubbery, mobile, and firm. That mobility earned it the memorable clinical nickname the breast mouse, because it just slips away from your examining fingers.
If the presentation is textbook a 20-year-old with a classic breast mouse, the clinical certainty is high. But here's the challenge. If it's so clearly benign, why do we sometimes need to biopsy it at all? Isn't that overtreatment?
That's an excellent point, and it highlights clinical caution.
Yeah.
In that age group, 15-25, if the imaging is absolutely classic, say a BI radius 2 lesion and the size is small, observation might be considered. But we often still require a core biopsy, or at least an FNAC, to definitively rule out 2 things. First, that it isn't actually a rapidly growing phyllodes tumor that we've misclassified on clinical exam. And second, that there isn't underlying atypia within the fibroadenoma itself, which, though rare, completely changes the risk profile.
So it's a safety net.
It is. While reassurance is the primary goal, we maintain a low threshold for sampling to ensure safety.
That makes perfect sense. The cost of missing a phyllodes tumor, which needs aggressive excision, is just too high. So when is excision mandatory?
Excision is necessary for specific criteria. If the lump is considered giant, which is typically over 3 centimeters, if there is rapid growth observed between surveillance appointments, which again suggests phyllodes,
Right.
if the patient has significant cosmetic concerns or anxiety, or critically, if it presents as a new onset lump in an older woman, say over 35 or 40, in that case, the risk of a carcinoma mimicking a fibroadenoma is too high to risk mere observation.
That continuous emphasis on age overriding the symptom is a really key lesson. Okay, next up, the most common diffuse finding. Fibrocystic change, FCC.
2. Fibrocystic change, FCC. This is a hormonal response, not a true disease, which is why it's so incredibly common in 30-50-year-olds. Its defining characteristic is cyclical mastalgia, so pain that waxes and wanes with the menstrual cycle, and a palpable nodular glandular breast texture.
Beyond the pain, what is the underlying pathology that creates this nodularity? I mean, what does fibrocystic change actually represent?
It's a spectrum defined by 3 underlying pathological changes. First, you have cyst formation, small to large fluid-filled sacs. Second, fibrosis, which is the deposition of dense connective tissue, making the breast feel ropey or lumpy.
And the third?
And third, apocrine metaplasia, where the ductal lining cells change their structure. Because this is a response to normal hormonal cycling, the patient often reports that the lumps seem to appear and disappear, or fluctuate in size and tenderness.
Since it's hormonally driven and non-malignant, management must be focused entirely on comfort and reassurance, right?
Precisely. The mainstay is reassurance, explaining that this is a normal physiological phenomenon for many women, which alleviates a lot of cancer anxiety. Symptomatic treatment includes NSIs for pain control and wearing a supportive bra to minimize breast movement.
And there are some other optional treatments mentioned in the literature.
Yes, which the source notes. Things like limiting caffeine intake or using evening primrose oil. The mechanism suggested for caffeine is that it might influence cyclic nucleotides that promote cyst development, though the evidence is a bit soft.
And evening primrose oil.
For evening primrose oil, the gamma-linolenic acid is thought to normalize fatty acid imbalance. But regardless of those, the core treatment is patient education and pain management.
Okay, let's look at a closely related but more localized finding, breast cysts.
3. Breast cysts. A cyst is simply a fluid collection within the breast tissue, usually presenting as a soft, sometimes tender, fluctuating lump. The appearance can be quite alarming if it emerges quickly.
And for diagnosis, you can aspirate them.
Right. Clinicians often use aspiration, which serves as both a diagnostic and a therapeutic tool.
What confirms its benign nature during that aspiration?
If the fluid is clear and described as straw-colored fluid, that is the classic sign of innocence. If the lump disappears entirely after aspiration and the fluid is clear, reassurance follows.
But what if it's not?
If the fluid is bloody, or if the lump is recurrent and refills quickly after drainage, then suspicion elevates immediately. In these cases, we need definitive USG plus cytology of the fluid to check for any atypical or malignant cells or any residual intracystic mass.
That gives us our baseline for fluid collections. Now let's pivot to the conditions defined by discharge, starting with intraductal papilloma.
For intraductal papilloma, This condition is an overgrowth of the ductal lining cells into a papillary structure, usually near the nipple. Its key feature is highly specific: spontaneous, unilateral, bloody discharge.
And often there's no lump you can feel.
Exactly. Often there is no palpable mass at all, as the lesion is tiny and located deep within the ductal system, often subareolar.
Bloody discharge is an automatic red flag that demands action. What is the surgical imperative here?
The surgical imperative is mandated by the risk of coexisting or underlying malignancy or atypia. Management requires excision via microdocectomy. This procedure involves identifying the specific duct that is producing the discharge and removing that duct in its entirety, along with the papilloma.
Which gives you diagnosis and cure.
It ensures both diagnosis and cure, eliminating the bleeding and ruling out any malignant cells hiding within that duct.
Okay, now contrast that with the other major discharge complaint, ductictasia.
5. Ductictasia. This condition typically affects middle-aged women. It involves the widening and shortening of the major ducts under the nipple, which leads to inflammation and accumulation of cellular debris.
And the discharge is different.
Very different. It's characterized by a greenish, sticky, or multicolored nipple discharge, and it can cause nipple retraction. A crucial piece of historical context here is the association with smoking, as the toxins and inflammation contribute significantly to these ductal changes.
How does the management approach differ so significantly from the papilloma, which required immediate duct excision?
Well, since ductictasia is an inflammatory process, the initial management focuses on resolving infection, if it's present, with antibiotics. We generally just observe mild cases.
And if it persists?
However, if the discharge is persistent, highly bothersome, or if the nipple retraction is severe and cosmetically concerning, a definitive surgical procedure may be necessary. Major duct excision, also known as Hadfield's procedure, which removes the main ductal system subareolarly.
Moving to the infectious realm? Breast abscess lactational mastitis?
6. Breast abscess lactational mastitis. The key presentation here is an acutely unwell patient. A tender, erythematous, hot lump accompanied by fever, overwhelmingly common in lactating women.
And how does the infection get in?
It usually enters through a fissure in the nipple, and the common causative agent is Staph aureus.
The management here has a really critical educational component about breastfeeding, doesn't it?
Absolutely critical. The management details emphasize that the clinician must strongly encourage continuing breastfeeding or milk expression from the affected breast. Stopping breastfeeding can lead to dangerous engorgement and actually worsen the infection.
So what's the treatment?
Treatment is systemic antibiotics, often targeting staph like flucloxacillin, combined with addressing the collection. For a confirmed abscess, this means incision and drainage, ANDI, or increasingly, USG-guided aspiration in earlier or smaller cases. Continuous emptying of the breast is essential for resolution.
Okay, now we have to address the pathological chameleon, the tumor that acts like a malignant beast even when it's technically benign. The Phyllodes tumor.
7. Phyllodes tumor. Yes, this is the one we treat with the utmost caution. Its key status is its borderline behavior. Even when the pathology reads benign phyllodes, its rapid growth rate is alarming to the patient.
So its key feature is that rapid growth.
It is, sometimes doubling in size over just a few weeks. Histologically, it has a distinct leaf-like architecture due to the massive stromal overgrowth that pushes the ductal epithelial cells into these fronds.
So why does a benign tumor require such aggressive surgery, specifically that 1 centimeter margin?
Because of its aggressive local growth and incredibly high propensity for local recurrence. Unlike a simple fibroadenoma, which rarely recurs, a Phyllodes tumor, if you excise it inadequately, will almost certainly grow back, and often more aggressively.
Which means you need an oncologic margin.
Right. Management requires a mandatory wide local excision with a 1 centimeter margin. This oncologic margin is necessary to clear all traces of that aggressive stromal tissue. Failure to achieve this margin upfront often necessitates larger, more complex surgery later on.
And this leads us back to the biopsy method. The source material emphasizes avoiding FNAC. Why is that?
Yes. FNAC, or fine needle aspiration cytology, often misdiagnoses Phyllodes as a simple fibroadenoma because it only gets single cells, not the necessary tissue structure.
It misses the architecture.
Exactly. The defining feature, the stromal overgrowth, and the leaf architecture is missed. This leads to an inadequate initial excision, a civil shelling out or enucleation, which guarantees recurrence. Therefore, a core biopsy is mandatory to obtain the architecture needed for the correct diagnosis and upfront planning of that aggressive 1 centimeter margin.
That distinction, the failure of FNAC to capture architecture, is a massive clinical lesson for the listener. Okay, finally, the ultimate mimic, fat necrosis.
8. Fat necrosis. The key feature here is a history of trauma to the breast, sometimes minor or even forgotten. This trauma causes fat cells to die, leading to inflammation and fibrosis.
And it's dangerous because it can look like cancer.
It's dangerous because it can look, feel, and image exactly like cancer. It causes classic cancer signs like skin dimpling or tethering due to the contracting scar tissue. On imaging, it can present as speculative masses or characteristic oil cysts.
So if the history is trauma, but the physical exam suggests cancer, how do we ever reassure the patient?
We can't, not based on history alone. Due to its ability to confuse both the clinician and the radiologist, it absolutely requires a core biopsy to confirm its benign nature. Only pathological confirmation of fat necrosis and inflammation and the exclusion of malignant cells allows the patient to be safely reassured and managed conservatively.
We've now detailed the unique fingerprints and management rationales across this whole spectrum, illustrating beautifully how management shifts from supportive observation, like with FCC, to mandatory oncologic excision for phyllodes. So we've used the ABC framework to form a clinical suspicion, and we've identified the key fingerprint of the condition. But suspicion is never enough in breast pathology, is it? We have to confirm the diagnosis and, more importantly, prove that the lump is truly innocent. How do clinicians establish that pathological certainty?
They utilize the globally mandatory framework known as the triple assessment. This is the non-negotiable gold standard for evaluating any new breast concern. It's a systematic approach designed to minimize the risk of missing a malignancy. If you miss any component, the assessment is incomplete.
Okay, let's detail the components. Number one is the human element.
Clinical examination. This involves the systematic physical assessment we discussed, the ABCs, checking the lump characteristics, the overlying skin, the nipple, and a thorough assessment of the regional lymph nodes, specifically the axilla. This establishes the initial risk level.
Component two involves visualization, seeing what the lump is doing inside.
2. Imaging. The modality choice here is critical, and it's dictated by age. For younger patients, typically under 30 or 35, the primary tool is USG, ultrasound.
Why ultrasound?
Young breast tissue is often very dense, which makes mammography less effective, whereas ultrasound excels at differentiating solid from cystic masses. For those over 40 years, mammography is the standard, often coupled with USG as needed because older, less dense, fatty breasts image better with X-ray.
The radiologist doesn't just describe the image, they have to score it. We have to talk about the BIRA system here. That's the standardized language of breast imaging.
Exactly. The BIRA system breast imaging reporting and data system is essential. It translates complex imaging findings into a standardized numerical score that communicates the likelihood of malignancy and dictates the next step in management.
Can you walk us through the critical scores, particularly those that drive intervention versus surveillance?
Certainly. BI-RADS scores 1 and 2 mean definitively normal or benign findings, requiring only routine screening. But the clinically important scores start at 3.
Okay, so BIRAS 3.
BI-RADS S3. This means probably benign. The chance of malignancy is very low, usually less than 2%. This score mandates short-interval follow-up, typically repeat imaging in 6 months, just to ensure stability.
And when it gets more concerning?
BI-RADS 4. This means suspicious abnormality. Here, the likelihood of malignancy is non-trivial. It can range from 2% up to 95%. This score mandates a tissue biopsy.
And BIRADS 5 is the most urgent.
BIRADS 5. This is highly suggestive of malignancy with a probability of over 95%. This also mandates biopsy and aggressive management planning.
So BIRAD 3 is surveillance and 4 or 5 is biopsy. That's a very clear decision tree based on standardized imaging criteria. That brings us to component 3, the definitive diagnosis.
3. Tissue diagnosis. Imaging can only categorize risk. Pathology confirms the truth. We need cells or tissue. The options are FNAC, fine needle aspiration cytology, which gets you cells, or the superior method, core biopsy, which gets a sliver of actual tissue architecture.
And core biopsy is preferred.
Overwhelmingly preferred for solid masses because, as we discussed with phyllodes, architecture is key to differentiating high-risk lesions like ADH and ALH from low-risk ones like a simple fibroadenoma. You just cannot accurately grade atypia or define stromal behavior with only cells.
The triple assessment ensures we never give reassurance without pathological certainty. Okay, now let's address the concept that dictates this whole exercise. The red flags. What are the clinical markers that immediately elevate suspicion and mandate biopsy, effectively forcing the benign disease to prove its innocence?
The physician's primary duty is vigilance. If patient presents with a finding that, even if it could be benign, has features strongly characteristic of cancer, the investigation must be escalated immediately. The red flags are the clinical markers that bypass any low-risk pathway.
What are they?
They include a hard, fixed lump, indicating infiltration, skin tethering or dimpling, which is often caused by the shortening of Cooper's ligaments due to tumor invasion, new onset nipple retraction, a very strong sign that an underlying mass is pulling the ducts inward.
And discharge again.
Bloody discharge in the elderly. Always assume cancer until proven otherwise. The presence of enlarged, suspicious axillary nodes suggesting regional spread. And finally, the unfavorable imaging signs. Any mass assigned BI or APS 45 features.
This brings us back to that powerful quote that really encapsulates the entire safety philosophy of this clinical domain.
It does. The guiding principle is safety and rigor. Every benign disease must prove its innocence radiologically and cytologically. You cannot manage a lump based on probability alone if any of these red flags are present. The triple assessment is the mechanism for obtaining that proof of innocence.
Once that innocence has been proven and we have a confirmed benign condition, how does the follow-up strategy differ? I mean, does a woman with a fibroadenoma get the same long-term advice as a woman with a history of ADH?
Absolutely not. The follow-up strategy is highly individualized. It's driven by the intersection of the patient's age plus the specific risk stratification, so the BI-RED score and the pathology. A young woman with a classic, stable fibroadenoma, BI-RED area, might only require a clinical check in a year.
But for ADH?
But a patient who has had an excisional biopsy for atypical ductal hyperplasia requires strict, regular surveillance, often involving biannual clinical exams and annual mammography MRI, potentially paired with chemoprevention.
The message is clear. The management of BBD is longitudinal. It's an ongoing relationship focused on meticulous risk mitigation, especially for those high-risk precursor lesions.
And the crucial instruction for the patient is always the same. Any change in consistency, size, or the appearance of new symptoms requires an immediate repeat assessment. Vigilance must be maintained because the breast is a dynamic organ.
And this brings us back perfectly to the highest risk group we identified right at the start in Section 1, the proliferative lesions with atypia.
Yes. When we talk about ADH and ALH, the follow-up strategy goes beyond simple monitoring. It enters the realm of cancer interception. The presence of atypia means the cellular machinery has already established a pathway toward malignancy. The risk is significant enough that clinicians use medications like selective estrogen receptor modulators or SERMs, like tamoxifen, to suppress future growth.
So you're effectively treating a future disease that hasn't even materialized yet.
That's it. That's fascinating, isn't it? It truly shows that the distinction between benign and malignant in this field is not a hard line. It's a continuum.
A subtle slope?
It is a subtle slope, and understanding that slope is key for any practitioner. For instance, sometimes a benign pathology like sclerosing adenosis can become so distorted that it mimics an invasive cancer on a mammogram, what we call a pseudomalignant appearance. The ability of the pathologist, through a core biopsy, to definitively say, this is complex but it is still benign, is what saves the patient from unnecessary surgery.
It's all about that deep dive into the source material to distinguish between benign complexity and true malignancy.
It is.
It seems like the entire structure of BBD management is just a continuous risk assessment built on the foundation of the triple assessment.
That's the perfect summary. Risk assessment, confirmation, and then tailored longitudinal surveillance, always with that low threshold for re-intervention if the risk profile changes.
We started this deep dive with just the daunting array of benign breast diseases and successfully structured them using the clinical architecture favored by specialists. We moved from simple anatomical variants to the crucial high-stakes distinctions between proliferation with and without atypia.
The essential takeaway remains the management philosophy. While BBD is incredibly common and largely non-life-threatening, the clinical approach has to balance reassurance and surveillance. Reassurance to alleviate the patient's immediate anxiety, and rigorous surveillance to manage that long-term risk profile.
And the high-yield takeaway for the clinician is knowing exactly when to pivot from observation to aggressive intervention, usually dictated by those atypical cellular features or the rapid growth we see in conditions like the Fibrocystic tumor.
The final clinical mandate, the ultimate summary line that captures the entire philosophy we've explored today, is this. In benign breast disease, management focuses on reassurance and surveillance, while maintaining a low threshold for biopsy and excision when atypical features arise.
That one sentence really does synthesize the balance between patient comfort and absolute clinical safety.
It does.
That line shows exactly where clinicians must spend their intellectual energy balancing compassion with caution. And as you emphasized, the greatest area of necessary caution lies with those high-risk, non-malignant precursor conditions, ADH and ALH.
They are the future of cancer interception.
Which leads us to our final thought for you, the learner, to carry forward.
Given the critical importance of the atypical hyperplasias ADH and ALH in defining a woman's future risk profile, a risk that's currently assessed primarily through family history and pathology, consider this. How might advancements in genetic testing, and I mean beyond just BRCA, perhaps looking at single nucleotide polymorphisms and increasingly sophisticated personalized surveillance plans, further refine the follow-up strategy?
So getting even more granular.
Exactly. If we can identify which specific women with ALH are most likely to progress to invasive disease through hyper-personalized genomic screening, how might that change the definition of low threshold for excision in the next decade? The field is constantly evolving, driven by the need to intercept risk before it crosses that critical threshold into active disease.